for Criminal Justice Studies at the Institute of Behavioral Research with Texas Christian University, and Janelle Pruder, who is the Director of Corrections Transition Programs with Task, Illinois. Dr. Knight joined the IBR faculty in 1991 and has conducted several longitudinal evaluations for treatment of probation and prison populations, including those with the Bureau of Prisons, the Residential Substance Abuse Treatment Program that's funded by the Department of Justice, and TCA's Drug Screen project. He works with several criminal justice agencies, including the Texas Department of Criminal Justice, Illinois Department of Corrections, Missouri Department of Corrections, Virginia Department of Corrections, and the Federal Bureau of Prisons on a number of issues, including those we're going to be talking about today. Ms. Pruder oversees treatment alternatives for safe communities, TAF services, for more than 5,000 individuals in Illinois each year who are incarcerated or are returning to their communities following incarceration. Working in partnership with the Illinois Department of Corrections, the Illinois Department of Juvenile Justice, and community-based service providers across the state, Ms. Pruder develops and implements plans and programs that help formerly incarcerated individuals successfully reintegrate into society. Today's webinar will focus on how good screening and assessment can help answer three key questions. How do you know if there really is a problem? How do you determine the most effective and efficient treatment for the problem? And how do you know if treatment is working? There will be a question and answer session at the end of the presentation. To ask a question, please type the question into the Q&A panel on the bottom right-hand corner of your screen. Please feel free to ask questions throughout the webinar, and we will answer them at the end of the presentation. We will do our best to answer your questions, but please understand that this is a very large webinar with several hundred people registered, so your question may not get answered, but we can always follow up afterwards with contact information and can reach us through the Reentry Resource Center. If you encounter technical or audio problems during the webinar, please call the WebEx technical support at 1-866-229-3239. We'll also share that number with you through the little Q&A box. We understand there are some technical issues you may not be able to resolve in time to participate in this webinar. For this reason, we are recording the event, and we will be posting the recording on our website. I believe the slides are already up, and the recording should be as well soon. The website is www.nationalreentryresourcecenter.org. We will also share that with you through the Q&A box. We really appreciate Dr. Knight and Ms. Pruder taking time out of their busy schedules to be with us today. And with that, I would like to turn it over to Dr. Knight.
Well, thank you. Good afternoon, everyone. And I must say this is the best-looking group I've ever presented to. Let's start with, let's see if I can figure out the technology here. I should be able to advance. Okay, guys, I cannot advance the slide. Okay, hopefully everyone can see the TCU IBR website slide that's currently shown on my screen. But everything that I'll be discussing today in terms of the manuals that are available, the forms, the conceptual guides that tie it all together, and the publications that come out of the project or the projects that we've been involved with at TCU are all available for free download at this website. You can see the address at the bottom, www.ibr.tcu.edu. So why are we discussing the role of screening and assessment today in terms of how it impacts correctional drug treatment? And I think the place to start is recognizing that we currently have a record number of offenders in the U.S. Over 7.3 million currently involved in the correctional system, as reported in 2007, and approximately 1.3 million actually incarcerated in the prison system. These are unprecedented numbers that when you look more closely at the population as it relates to drug use, we see that nearly 2/3 to 3/4 report that they are regular drug users, with approximately half reporting that they meet drug dependence or abuse level criteria. And when you specifically look at the types of crime that are being committed that are drug-related, we see that the percentages are fairly high for violent, property, and drug trafficking crimes, with the costs totaling approximately $107 billion. So clearly, large correctional population that's heavily drug-involved, and if we're trying to reduce recidivism rates, this is ideally a targeted population that we can address a specific issue, and that is being drug use in hopes of impacting a reduction in return to custody. So for today's webinar, there are really 3 points I want to touch on. The first is, with any correctional population where we're trying to determine substance use problems, how do you know if someone has a serious drug problem? The second point is, how do you determine, once you have identified the individuals who have problems, how do you determine the most effective and efficient treatment approaches to address those problems? And finally, how do you know if the services that are being provided are having a positive impact? Particularly in this era of evidence-based practices, there are a number of folks out there who are trying hard to get these practices into effect, but sometimes not with the greatest fidelity. And the question is, really, are you having the intended impact you're meaning to have? So let's start with, then, how do you know if someone has a serious drug problem? The key, I think, is to make sure that you begin with a good screening instrument. The one I want to present on briefly is one we've developed here called the TCA Drug Screen that's widely used now. And it's short. It's only 2 pages, where the first page specifically asks questions as they relate to drug dependence, and then the remaining questions trying to assess more specifically the need for treatment and the history of treatment episodes. In Texas, where this has been administered now for a number of years, to all incoming prisoners, we see that about half, 47%, meet the threshold that would correspond with a diagnosis of dependence. And through looking through file reviews and looking at other corroborative information, another 24% will come up with measures that would suggest that these individuals also have drug problems. So in total, in Texas, we see that a treatment referral for these individuals includes everything from a very intensive therapeutic community approach to less intensive brief interventions, all the way down to drug education and 12-step groups. So very general, broad-brushed treatment options for these individuals. But the key is that they're able to use an instrument that is doing a fairly good job in terms of classifying these individuals correctly as having drug problems when they really have a serious drug problem. There are a couple other instruments out there that I think Roger Peters' work has shown to be equally good in terms of instrumentation. The other is the drug use section out of the ASI, the Addiction Severity Index. It also had a 84% overall correct classification in his study. And the other is an instrument developed at a CSAT called the Simple Screening Inventory, which had an 84% overall correct classification. Now, I know there's a number of you who currently use the SASE, and just wanted to report that in that study, the study revealed that it had about a 70% correct classification, and then a number of other instruments were down around the 30%. One of the key aspects, I think, of the study was that not only did it show that these instruments are good at identifying those who have a drug problem, but they're also good at identifying those who do not. That we need to really be able to classify both groups accurately in order to do a good job to identify those who have a drug problem versus those who do not. Yes, this is self-report, primarily through interview, but also in some cases it can be self-administered. I know a number of folks question use of self-report, but I think as with any self-report, if administered the way it's intended to be administered in a secure setting where the clients can report confidentially without fear of retribution for disclosing their drug use. We see that, in fact, most will freely disclose their drug use on these forms. Conversely, if the instrument's provided in a manner where there's no or limited instruction given and there's fear of consequences for reporting drug use, I think it's needless to say that that's not the best way to get a good self-report. There are also, though, I need to keep in mind that there are other measures of drug use problems. One commonly used within the correctional setting is the use of biological assays, including urinalysis, hair testing, sweat patch, blood, and saliva. Testing positive on these tests, particularly when they know they're going to be tested, is a great indication of problems associated with drug use. And finally, there are a number of other avenues to secure information about drug use, such as through surveys of family and friends, if you're afforded that luxury to be able to survey them. But I think the one that most systems have readily available to them are a criminal history records review that can be conducted. Are there prior incidences of either dirty urine tests, arrests associated with drug use, perhaps even a self-reported drug use in a pre-sentence investigation report. So that was quickly a scan of what's available through the initial screening process, and that being the key to make sure you identify those who have a drug use problem. But once you identify them, obviously that's not enough. The next question becomes, what do you do once you have those individuals identified? And specifically, how do you determine the most effective and efficient treatment? Unfortunately, in this day and age, I think most systems continue to provide a one-size-fits-all approach. We tend to put a manualized program into place, and anyone that's identified as having a problem is then asked to go through that program. I'd ask that folks start thinking about ways to be a little more effective and efficient in their approaches, and more specifically, how we might be able to adapt or tailor the treatment approaches so that they're better suited to the needs of the clients. I want to point you to an excellent publication from the National Institute on Drug Abuse that actually lists some of these scientifically based approaches. And this is the Principles of Drug Addiction Treatment, published by NIDA in 2000. You can get access to that online. But that one is a general one. They have one specific for criminal justice populations as well, which really lays out some of the specifics that treatment sites need to consider, such as the use of medications to assist in the delivery of treatment with those involved in the criminal justice system. That is available as well through the National Institute on Drug Abuse. One of the basic principles, though, is noted in that publication, and when we're talking about effective and efficient treatment and trying to identify what is best suited for the individuals involved who have substance abuse problems, at the most basic level, if we're looking at achieving the highest efficiency, we need to do a good job at making sure we can distinguish between those who have a severe drug use problem with a less severe problem. And once that's identified, making sure that the most intensive treatment options are reserved for those with the most severe problems. Research has been pretty clear that providing low severity individuals with more intensive treatment options will have limited to no effect at all, while those with the high severity problems really need those more intensive treatment options, such as the residential therapeutic community, followed by longer-term aftercare programming, that there really needs to be the continuum of care that's commonly referenced when talking about treatment for those with the higher severity needs. Those with the low severity needs, frankly, can probably benefit from very minimal intervention. So when we're talking about modifying or adapting a one-size-fits-all approach, in many cases what we can do is within a given program, try to shift some of our resources towards those with a higher level of severity. For example, perhaps lower counselor-client caseloads, number of hours of services provided, maybe lower the required number of hours for those with the low severity and increase it for those with the high severity. And another option would be among those who have high severity levels of drug use, trying to provide programming specific to some of their needs, such as anger management or motivational enhancement strategies for those who don't want to be in treatment. There's really no need to provide those intensive supervisions for everyone. If you have a motivated client, you really don't need to be providing motivational enhancement strategies. But we can tailor some of those interventions for those who really need them. The evidence is clear that when an approach like that is taken, the outcomes reflect the benefits of doing a tailored approach. If you look, for example, at a study we conducted a few years ago with an in-prison therapeutic community, the yellow bars in this graph represent those who were eligible for but did not receive treatment, primarily because they didn't have enough time left to serve. There was a comparable group who, though, did receive treatment and completed the full continuum. When you look at those in the low severity group, notice that the 3-year return to custody rate is only 29%, which is pretty good for the no treatment, but it's 22% for those who went through treatment. Slightly better, but not a lot better. When you look at the high severity group, over half of the no treatment group were returned within 3 years, compared to only 26% for those who went through the continuum. So clearly the biggest bang for the buck, if you will, for those who went through treatment is really for those who received the treatment for the high severity, those in the high severity group who received treatment. The next slide. So that really speaks to outcomes and how we adapt treatment to be more effective and efficient. But one thing I want to stop for a minute and refocus on is for folks to think about what is actually being delivered. There's a great emphasis right now on evidence-based programming, which is often translated as some manualized package that you either purchase or download and introduce into a program as if that's what's going to get you the good outcomes. The reality is the evidence-based, the manualized programming is still only as good as the delivery that takes place to present that information to the clients. And oftentimes this is still delivered in a very didactic, dry manner, which the clients, particularly those in correctional settings, do not respond well to. So one of the challenges I'd like to put out there is for those involved in the correctional treatment arena to think creatively as to how the information is provided. In particular, if you think of your younger clients who have problems with methamphetamines, whose attention spans are very short, or longer traditional didactic approaches are just very poorly suited for these individuals. They need much shorter, highly interactive approaches in order to achieve and maintain their attention. One of the strategies that have been developed, one of the strategies that has been developed out of Texas Christian University that we've incorporated into our interventions is called mapping, knowledge mapping. And it's essentially a visual representation strategy that tries to present the information to the clients in a way that's visual and not didactic. And just to give you a quick illustration in terms of how this can be used, I want to just describe a little bit more about myself, which, if I get this to work, is something you could do with your clients who are trying to find out more about the problems that they're presenting and how you might achieve some solutions. In this case, I'm from Fort Worth. I am employed at TCU. I'm married with 2 children. The role that I play at TCU is as an IBR scientist, specifically as the Associate Director of Criminal Justice Studies, and I'm completely funded through NIDA grants. The studies I conduct are specific to addiction studies and really center on looking at treatment effectiveness, specifically follow-up outcomes and process, and within process, really looking at client engagement. And the other aspect of our studies here include a focus on organizational change strategies. And in the fourth and final quadrant, it's really specific to today, and that is, this is part of the CSG webinar. The information that I'm presenting can be found on the IBR website, but today's focus is on screening and assessment. Tying back to, again, the addiction studies that we've conducted here that are this whole mapping strategy that I've just presented is listed in SAMHSA's NREP list of evidence-based programs and practices. I provide this as an illustration simply to make the point that if I were to take this away and quiz you, I guarantee you'd have a better recall of this information than if I just put up a bunch of bullets for you to try to recall. That's our way of trying to help inmates, trying to help probationers, those involved in the correctional system, gain a better understanding of not only the problems they're encountering, but hopefully the skill sets, the solution-based focus areas that they can begin looking at in terms of how to overcome those problems. Third point I'd like to touch on briefly is how do you know if the services that are being provided are having a positive impact? When you typically hear about correctional treatment, we think about long-term outcomes and whether or not there's an impact on that. And indeed, as Don Andrews' study back in the mid-90s showed, a meta-analysis of many other studies, that when you provide appropriate treatment, if you look at the column on the far right, appropriate treatments being those that actually meet the needs of the client, you can reduce recidivism rates by as much as 30%. If you simply sanction the individuals or provide inappropriate treatments, and by inappropriate treatments, it's frankly defined simply as not providing the services that the individual needs. You can notice there that it goes in the other direction. You're actually potentially making the situation worse. In other words, by providing sanctions or inappropriate treatments, you're increasing the likelihood that they will return to custody compared to if you had not done anything at all. So the point is, in terms of outcomes, we do see now through a number of studies that treatment can work. It does work when provided with fidelity and implemented the way it was intended to be implemented. But that's a focus on outcomes. And as most of us know, we can't wait around 3-4 years many times to see if what we're doing is working. And we also know there are a number of other factors that go into play as to what those outcomes end up being, that it's not just the drug treatment that's provided while the individual's in the institution. It also has to do with housing and employment, post-release treatment options, supervision. There are a number of factors that have an impact on that post-release recidivism rate. So when we talk about outcomes specific to drug treatment, what I'd like to do now is guide the focus of the talk on what happens during treatment and suggesting that we can look at what happens during treatment as a way to measure treatment effectiveness. This is a model developed by Dwayne Simpson, the director of the Institute of Behavioral Research for many years. And essentially what it illustrates is on the far left, we have the individuals coming into the system who vary on the level of their severity and their readiness for treatment. This impacts obviously on that early engagement aspect of treatment, whether or not the individual participates in treatment, and whether or not they form that relationship with the therapist that's needed for recovery to continue. After early engagement, there are those initial signs of early recovery, particularly for the offending population where you see changes in self-reports of thinking patterns as it relates to criminal thinking. Individuals begin taking on responsibilities for their actions, begin admitting that it wasn't necessarily the victim's fault. They begin acting the way that you intend them or want them to act. And then finally, this all leads to the ultimate goal of retaining them in treatment with the follow-up outcomes to follow of reduced drug use, reduced crime, and improved social functioning. The key to note here in this is that there really is a sequential staging here of beginning from the time they get into treatment to the time they get out, and that anywhere along the way things can blow up. If you don't get them engaged in treatment, they're likely not to achieve those early stages of recovery. We could also get them engaged in treatment, but never really achieve that change in criminal thinking that you're trying to achieve. So So when we're looking at measures of outcomes or measures of treatment effectiveness as it specifically relates to treatment, then what we've been doing for years at the IBR is to look specifically at this black box of treatment, early engagement and early recovery, to see if we have measures that demonstrate changes over time in this setting. We have a number of measures that we've developed to do exactly that, to capture these changes. I know many of you are familiar with our forms, but at intake, we have an intake assessment similar to the ASI that you can download. We also have assessments of background and risk information, as well as family and friends in terms of the networks that are formed. We also have assessments of client motivation, psychological functioning, social functioning, and criminal thinking. Collectively, these make up a nice comprehensive set of measures for baseline assessment. But when we're talking about determining if there's change over time, some of these assessments are valuable when reassessed to determine whether or not that change is occurring. For example, if you have a client that's showing high levels of depression at intake, which is measured in our psychological form, if it's readministered at the middle of treatment and again at end of treatment, you should hopefully be able to show that there are improvements on that dimension over time. Likewise, measures of hostility, which are found in the social functioning scales, you should be able to show that while many of your clients come in with very high hostility levels, that by the time the end of treatment, hopefully by the time orientation is completed, those anger levels have dropped. And just for another example, on the criminal thinking scales, you should be able to show within a correctional treatment setting where one of the focus areas is on criminal thinking, that your clients do improve on these scales over time. We have a number of these forms. They're all designed to map onto that treatment model that you see on the top part of the slide. These can all be downloaded and administered. We have much more information on our website about the instruments, but they are all free, and we have some tools that can help you process that information once it's been obtained from the clients. And I think the key to this is to be able to show that graphically over time, when you chart this type of information, you can, in fact, show improvements over time. If you look at this particular chart from a probation substance abuse treatment facility from a few years ago, clients came into this facility with a fairly high level of problems with anxiety, problems with depression, and low self-esteem, anywhere from 15 to 26% of the sample. Notice that when this form's readministered during the middle of treatment, again at the end of treatment, how the rates dropped to nearly 5% only having problems on these dimensions. So this was a good way for this particular program to document that they were in fact impacting those areas that they were intending to impact, which according to the model should ultimately improve retention and improve outcomes. So with that, I want to stop and Janelle, the floor is yours.
Thank you very much. What I'm going to do is I'm going to talk to you this afternoon about how in Illinois we've taken some of these tools developed by TCU and put them into practice in our correctional programs. And specifically, I'm going to focus on some of the work that we're doing at screening, treatment readiness, ongoing assessment, and discharge from prison-based treatment. And I really want to look at this with you today in the context of the 3 questions, the 3 points that Kevin raised with us today. Just before I move into screening, I just want to give you a quick overview of some of the work that we're doing related to substance abuse programming currently in the Illinois Department of Corrections. And I'm just going to give you kind of a quick overview related to some of the topics and areas that I'm going to cover today. One is that we are currently screening every adult coming into our Illinois Department of Corrections for a substance abuse problem. And I'll talk more specifically about that when we move into the screening portion of the presentation. From there, we have 2 all-male drug treatment prisons, one which is Sheridan Correctional Center, which is located in northern Illinois and houses about 1,600 men that are all in treatment, and also Southwestern Correctional Center, which is in outside of St. Louis, which houses about 670 male inmates all in treatment and includes a 150-bed methamphetamine treatment program. In addition to that, we also have drug treatment units that are housed throughout our other prisons, both for men and women. So I just wanted to give you that context in terms of how and where we're implementing some of the TCU tools. So, as Kevin mentioned, how do you know if someone has a serious drug use problem? And it all starts with screening. So, why is screening important in the context of the work that we're doing? One is that it allows us to very quickly determine who appears to have a serious substance abuse problem. And, I don't know everybody that's on the call and what you're dealing with in your own states, but quickly is very important to us because you'll see in a moment we are screening a very high volume of offenders coming into our system every year. I think the other thing that's important related to screening is that you target the right population for the right services. Again, you're matching the most intense, severe cases of dependence with the most high-intensity resources, and that you're matching high intensity with high service. And then the last thing why screening is important is that we want to make sure that we're using our limited resources wisely. Not only are we getting the right people into the right programs, but that we're using our resources because we don't have unlimited treatment resources in our system, that we're using those resources for the right people. So let me talk a little bit about what we're doing related to screening in Illinois. We currently have 3 male reception centers where all the men come into the system and 1 for women. And it goes back about 8 years ago, we implemented the use of the TCU Drug Screen 2, which Kevin talked about briefly earlier. We administer the TCU as part of a brief interview that we do individually with every man and woman coming into the system. And in 2010, fiscal year 2010, we screened over 32,000 men and over 3,000 women for a substance abuse problem. And you can see that related to the results of those screenings, a little over 15,000 men screened as substance dependent and even higher numbers of women screened as substance dependent, which I'll get into a little more in detail in a minute. So the percentages of substance dependence really match some of the data that Kevin presented earlier. So what we're seeing in terms of how men are screening for substance dependence is consistent with the data that TCU is seeing out of Texas, which is about 47% of the men are screening as substance dependent as part of the screening and the brief interview. Interestingly, that jumps to almost 69% for women. And I just want to focus in on that for a second. I think part of that has to do with the sheer volume. And so we are able to spend a little more time with the women as part of their screening process where we're not able to do that with the men. And so in addition to be able, not only to be able to do the screen, we're able to gather a little more information that then informs the screening decision. And so for the women, it's not just based on traditionally the self-report, it's also based on other information and other data that we have available through the Department of Corrections records. And then as you can see, when we get into the conversation about limited resources, we have over 15,000 people, 15,000 men screening for dependence and only 2,800 beds. And, for women, upwards of 3,000 screening dependent and 440 beds. So again, looking at how do we target the right people, not only for the right programs, but also because we're in the context of limited resources. So I just want to touch on some of the promising practices that we've developed as part of this screening process over the years. And again, we did this in consultation with TCU. And one of the things is when you have a chance to go take a look at the screen, one of the things we implemented in Illinois is we actually began screening starting with question 10. And that question is, what drug caused the most serious problem for you? The reason we did that is because we had been starting with what's known as the DSM-4 questions, which are the questions that are related to the scoring. And what we were finding is that clients were getting confused, they didn't know how to answer the questions, and so that if we started with the question, what drugs have caused you the most serious problem, we can immediately engage them in a conversation about their drug use, which also has increased the number of people that are actually screening dependents. Another practice that we put into place is in order to ensure that we're promoting validity in the implementation of the screen is developing a set of standard secondary questions. So it's really important as you're screening people that everybody is asking the same questions. And if a client doesn't understand a question for whatever reason, that there are standard secondary questions that all the screeners are using so that they don't just go off into their own questioning, which may happen later after the tool is administered, but that everybody's asking the same set of questions. So for example, one of the questions that we ask is, did you ever try to cut down on your use, and were you unable to do that? And so if the client is having difficulty answering that question, one of the secondary standard questions that we have is, did you ever try to stop or ever try to use less, and you just, it didn't work. And so that's part of the development of standard questions to ensure that the tool is being administered the same way in all locations with all screeners. And then also, promising practices, again, we do this a lot with the women, and sometimes the volume with the men has been preventing us from doing this, but as much as possible, validating their self-report with other records. And what we see when we do that, and what's consistent with the work of TCU, is that when we are able to validate with other information, the instance of dependence actually increases. All right, so let me move to treatment readiness, which is a topic that we haven't talked about yet today. One of the things that we started to do in Illinois is develop treatment readiness groups, and I'll talk about the different places where we're currently doing that in the system because we have a couple different models. Why do treatment readiness? One is, it's really designed to increase the offender's motivation prior to them entering the prison-based treatment program, which is critically important. We've done the groups in a number of different ways. We've done mostly open groups. We have done closed groups on some exceptions, and I'll talk about that in a minute. And again, the curriculum that we're using comes from TCU, which is a 4-week curriculum called Getting Motivated to Change. So we've implemented the treatment readiness groups in several different ways, and I want to talk you through the different ways you might be able to do this and then have a little conversation about open versus closed groups. So one of the ways we've implemented the treatment readiness groups is at our reception and classification centers. So once people are screened and we know that they're dependent and the Department of Corrections has approved them to go into treatment, we have some offenders sometimes waiting anywhere from 2 to 8 weeks at those reception centers to enter treatment. And they were sitting there with virtually, nothing to do all day. And what we were starting to see is that the motivation was declining, even though they were someone that said, I wanted to go to treatment. So one of the ways that we've implemented the Getting Motivated to Change curriculum is at our reception centers. We do this now at all of our reception centers. And one of the interesting things is at the Graham Correctional Center, we actually implemented a closed group, which means that people would go from beginning to end, 4 sessions, and then we would start another group. At the other locations, we've implemented open groups, so people can come and go at any time because we never know when somebody's going to be transferred from the reception center to the actual institution. And so, interestingly, with the closed groups, one of the things we saw is that when we got to session 4, and there were still people that had not been transferred to treatment, and they knew it was the last session, the session was very disruptive. People did not want to participate because where they were left was, I don't know when I'm going to be transferred, and I'm going to have nothing to do until I am. And so one of the things we learned from implementing this at the reception centers is that it's probably best to do this as an open group so people can come and continually participate even if they get the same group more than once until they're transferred into treatment. Or if you use a closed group process, that you ensure that there's some kind of ongoing group process that's available for people until they get into treatment. The other way that we've implemented treatment readiness is we've done it at the institution prior to them entering treatment. So, for example, Sheridan Correctional Center houses over 1,600 men. we actually started a pre-treatment portion of that program so that when the men come in, they're in a brief period of pre-treatment, and then as beds become available in the treatment program, they're moved over into that program. Again, using the same curriculum, getting motivated to change. And then the last way we've done treatment readiness throughout our system is to actually have it be in a separate unit in another prison location. So, for example, a number of years ago, prior to being able to enter Southwestern Correctional Center, you would go to Robinson Correctional Center for your pre-treatment groups. You would be at Robinson Correctional for 8 weeks, and if you completed treatment readiness, you were allowed then to transfer over to Southwestern. Unfortunately, we had to eliminate that program due to resources, but what the treatment staff at Southwestern Correctional reported is that those clients, having gone through an 8-week treatment readiness process, came into treatment much more motivated than what they're currently seeing now with people not being afforded the opportunity for treatment readiness. And I cannot advance the slides. Ooh. Let me try again. Oh, there we go. So why treatment readiness? One, again, it's designed to increase treatment motivation prior to the onset of treatment. And clearly one of the things we have seen over the years is that it improves outcomes. And then another reason, again, is ensuring we're targeting the right people for the right programs and using our limited resources wisely. So a couple things that we've noticed in using the treatment readiness groups these different ways is some clients have opted out of treatment because they get into the treatment readiness groups and they realize this is not for them and they don't want to participate in treatment. Or we have clients that come into the group that we realize are not a good match for treatment. And so then they're taken off the treatment list and transferred to another location within our Department of Corrections. Okay, so I'm going to move to ongoing assessment. And again, Kevin posed the question to all of us, how do you know if the services that are being provided are having a positive impact? And so there's a couple ways we're going to look at this. And one is, how do you know as the person is going through treatment that the services are effective? And then how do you look at the long-term outcomes? So one of the tools, again, developed by TCU that we've implemented at Sheridan Correctional Center is the client evaluation of self and treatment. This particular test has 5 different domains, so there's 5 different sets of questionnaires that the inmate is answering, including treatment needs and motivation, psychological functioning, social functioning, treatment engagement, and then the criminal thinking scales. Again, we've implemented this at Sheridan Correctional Center, which is one of our all-drug treatment prisons. Just so you know, the substance abuse treatment program there is done in 4 phases. So you start in orientation, which is phase 1, and work your way through based on your progress. We administer the client evaluation of self and treatment at intake, with the exception of the treatment engagement scale. Because the person has not yet fully engaged in treatment, we don't use that scale at intake. It's pointless to use it at that point in the system. We administer the test prior to every phase change in treatment. And, one of the things that I think sometimes the pitfall we fall into is we use these tools and we have all this data, but then how are we using the results? So one of the things that we've done at Sheridan is we're using the results for treatment planning, recommending additional services, clinical supervision, and then looking at the overall effectiveness of the program. So I just want to spend a couple minutes giving you a couple examples of that. And, Kevin touched on some of this, so I want to go into a little more detail about some actual case studies where we've used some of these scores to not only impact the performance of the program, but also impact the individual performance of a client. So the first case study involves a client by the name of John who scored very high on the hostility scale during phase 2 of treatment. So one of the things we've seen in our program is that clients do tend to start treatment and their hostility scores tend to be elevated, But what we see over time is that those scores start to come down. And so now we have somebody who is approaching the end of phase 2 of their treatment and is still extremely hostile and is scoring very high on the hostility scale. One of the things you should know is that we do review these scores with the client individually in their individual sessions, so they know and get all of this information. And so what happened with John is in the review of the score, the counselor did a couple things with him. One is that he recommended that John start to attend anger management classes, and then he incorporated that into part of the treatment plan. So not only looking at a treatment plan related to anger management, but also incorporating into the plan that the individual sessions address that hostility score, and that the goal is to reduce that score at the next testing. And so the clients are fully engaged and fully participate in the process. The next example relates to improving program performance. One of the things that the treatment engagement scale measures is how satisfied clients are with their counselors. And so one of the things that is done at Sheridan Correctional Center by our treatment provider is that each counselor with their clinical supervisor sees how their clients are scoring them related to their satisfaction with treatment. And so related to Mary, who's one of the counselors out there, one of the things that her supervisor was seeing is that she was consistently being rated low by her clients on their satisfaction. Now, one of the things you should know is that the counselors they don't get the information about which clients scored what. They see the aggregate results of the clients that they're working with. And so one of the things that the supervisor did is reviewed these scores with Mary in her clinical supervision, and then they created an individual development plan so that Mary could really go to work on what are some of the things that she can do to improve her treatment services so that those scores continue to go up. And then shifting from how do you look at how is treatment working while it's occurring to the overall outcomes, I just wanted to share with you some of the outcomes that we're seeing out of the Sheridan Correctional Center, which are long-term outcomes. And these findings come from a recent study done by Dave Olson and Jennifer Razan. These were independent evaluation results. And so we looked at a couple different measures regarding how well Sheridan was doing. And so what we saw was that 86% of those released from Sheridan, and this is 6 years of data, started treatment in the community. 71% that started treatment actually completed treatment, which if you look at and you're familiar with the TEDS data is significantly higher than most criminal justice clients. And for those that started treatment and completed treatment, there was a 32% recidivism rate overall. And what we see in our state last year is that the overall recidivism rate was actually 51%. So significant reductions in recidivism when people leaving Sheridan start treatment and complete treatment. They're much more likely to then not recidivate. And this is 3-year recidivism data. So I want to move into the final part of my presentation, which is looking at one of the evidence-based tools we're using related to discharge from prison treatment, and how do you look at risk as well as what is the next best step in treatment for the person coming out of prison. And so at the Southwestern Correctional Center, we implemented the tool developed by TCU and some of its partners called the Inmate Pre-Release Assessment, or the IPASS. One of the really unique things about the IPASS is that it's designed specifically for clients leaving institution-based substance abuse treatments. It measures both the risk of relapse as well as the risk of recidivism. And I can tell you just in my experience with our programs, I think, are fairly sophisticated in looking at the risk of relapse. And one of the things that we were really missing is how do you marry that with looking at the risk of recidivism and including all of that in your post-discharge planning. The IPASS comes from a couple different scores of TCU tools that we're using. It includes the score, the original score from the drug screen, the screening process that we talked about, the engagement scale from the SEST, and then it also includes a criminal history screen, which is one of the things that we administer prior to coming up with the score for the IPASS. Okay, and I talked about this. We've implemented this at Southwestern Correctional Center. One of the things we did prior to rolling this out for all of our clients is we did a pilot. And one of the reasons we did a pilot is we wanted to establish a baseline score. And so based on the pilot, we created 3 risk levels, and we did this in partnership with our treatment provider down there. And so what we looked at is that, so the scores for the IPASS actually go from, I believe it's -9 to +16. I might be a little off on that, and maybe Kevin can answer that question later. So we really felt that our high-risk clients were clients that scored 9 or more. Our medium-risk clients were 0 to 9, and then low risk was anybody that scored below a 0. And again, creating these risk levels so that we ensure that now as somebody's leaving the institution and going into the treatment, community-based treatment, that we're matching them with the right services and the right supervision. So currently how we apply these scores, and we've actually rolled this out now for everybody leaving the institution, is that we use the IPASS score to inform us on a recommended level of care for post-release treatment, community-based treatment. It doesn't dictate the level of care, but what I mean by that is if we have somebody that appears to be very high risk, we might want to look at a more structured treatment setting for them in the community. So we may want to look at a halfway house or a recovery home coupled with intensive outpatient. Your lower risk clients might be able to go home with an intensive outpatient program. And so we use the score and the risk levels to inform our decision about what level of care somebody will receive in the community. And then what we're hoping to do down the road, and we haven't implemented yet, and we're in the process of looking at, is how can we use these scores to not only inform the treatment level, but also inform the level of parole supervision that someone gets in the community, as well as the level of intensity of their task case management services. And so we're hoping to take this and move this forward to not only impact treatment, but also impact supervision levels. Again, ensuring that we're not giving high-intensity services to low-intensity clients. And I think that wraps it up for me, and I'll turn it back over to Alexa so we can do some questions.
Great. Thank you so much, both Dr. Knight and Janelle. Fantastic set of presentations. And now we're going to transition to the question and answer session. I want to remind everyone on the call that if you have a question you'd like to ask, please type the question into the Q&A panel, not the chat panel. It's a little bit harder for us to manage. So please, if you have a question, use the Q&A panel that's on the bottom right-hand corner of your screen. And we will do our best to answer your question today. We have a number of questions already queued up, and we will try and make sure that we get through as many of them as we can in the next half hour so that we have left. So going back to one of the early points in the presentation, I think, Dr. Knight, that you were touching on, a question about whether the assessments you were discussing or others have been adapted for an American Indian population, and maybe you could also talk about some of the other special populations that are often involved in corrections, like women, those sorts of things.
Right. We have looked at the application of these instruments across a number of special populations, but not specifically American Indians, although they have been administered to groups that include American Indians. We have not broken out the analysis specific to that group. What we have found, though, is that the reliability of the different scales hold up quite well, pretty much regardless of how you cut the sample in terms of race, ethnicity, age, gender, along the basic lines of sociodemographic characteristics.
A question about I think one of your points related to the tools you were talking about and how you take a tool that you have developed and make it valid. I think they're referencing maybe a tool that they have sort of developed in their own jurisdiction.
Right. Typically what we do whenever we develop, now if we're talking about assessments, when we're talking about instrumentation, we have developed these based on prior research instruments we've used, adapted them a little more for clinical practice, and then typically compare the outcomes with whatever gold standard there is, for example, within our area. So if you look at depression, there are scale of depression. We've compared that with the Beck Depression Inventory. That's just one example. Most of our DSM criteria or our DSM scales have been compared against the diagnostic interview schedule. The study that Roger Peters did, for example, with the TCA Drug Screen and those other brief screening instruments were all compared against that gold standard. So by doing so, what you're hopefully able to do is show that these brief instruments hold up fairly well in comparison to these lengthier clinical assessments. They're never going to be quite as good as, if you will, a 3-hour interview with a psychologist to get real good diagnostics. They're not intended to do that. The intention of these brief screeners is to give you a quick and dirty way of sorting individuals into likely categories that you can then pursue more detailed assessment for those you're interested in pursuing.
Okay, great. Another question about the TCU screening tool and whether it addresses any issues that may be specific to veterans, like traumatic brain injury, post-traumatic stress disorder, things like that.
Right. We do have a whole series of instruments available on our website, many of which I did not go into discussing. One of those is a one-page form on trauma that is specifically based on the VA's post-traumatic stress disorder civilian version. We have others such as on health from the World Health Organization, on mental health assessment. When we haven't developed them ourselves, we try to go out and look for public domain instruments that we're able to adapt and fit into our menu of options.
Great. Question starts out, our county jail has an in-custody drug and alcohol treatment program, but I do not know what screening and assessment tools they use. Would it be helpful if we use these tools for our reentry clients?
Janelle is much better to answer this than I am because they've looked at these instruments and interventions within jail settings. Janelle?
Yeah, I really believe that the screening tool, the TCU screening tool, is something that you can use in a variety of settings. We not only use it to screen when somebody comes to prison, we're also using it as screening for probationers. So I don't see any reason why it couldn't also be applied to an intake process in a county jail.
Yeah, the challenge in jail settings is simply that they're so transient in nature with the individuals coming and going that doing ongoing assessment is almost impossible in many cases. Where it is possible, we usually suggest that you try to at least get an intake and then a discharge assessment so that you're able to document change. With the interventions, it's also a little bit of a challenge because, as with most interventions, the ideal is to have a closed group setting where you pick off the last session in your next session. In jail settings, that's typically very challenging to do because of the composition of the group changing each time. And in those settings, we found that the materials, the interventions we've developed can work, but it's not necessarily the ideal.
Our DOC uses the level of service case management inventory as the assessment tool. Do you have any information on how effective it is in correct assessment compared to the other tools that you mentioned?
Well, there are some studies out there, but that's, as I understand it, more of a risk assessment, and where our assessments are more geared around service need, drug treatment needs. I'm not really qualified to comment on comparisons of that particular instrument, but there are a number of really good risk instruments that are out there. One of obviously is the LSIR. Another more comprehensive assessment that's been developed recently that I believe is in the at least free to use is the ORAS, the Ohio Risk Assessment instrument developed by Ed Latessa. So there are some really good instruments out there on the risk assessment side, but the ones we've developed are really more specific to drug treatment needs.
Okay, thank you. And then to follow up on that point, maybe just if you could talk a little bit, one of the questions that came through is how does risk of recidivism align with severity of drug use?
Well, the evidence is pretty clear that the higher the risk of drug use, basically the more severe your problems are with drug use, the more likely you are to recidivate. And it's not just a direct correlational relationship. It really is more exponential in that those at the more severe level are many times more likely to recidivate. And that's why the research now is pretty strong in suggesting that that's the group that needs to be targeted for the reception of services, because this is the group that accounts for most of the crime once they return to the community and return to custody.
How do you suggest jurisdictions integrate a short screener with the family and friends assessment?
Well, the family and friends assessment is we now have it as a one-page assessment, as we have with all of our instruments, boiled them down to a series of one-page assessments. The CEST that's often referenced, that Janelle referenced earlier, is really a compilation of 4 of those or 5 of those instruments, depending on when it's administered. So the family and friends assessment is a one-page assessment that can be administered at baseline, and again, repeated over time, really geared toward looking at support that the individual perceives from family and friends in their efforts to recover.
A question specific to Illinois. How does Illinois work with the Department of Corrections to place individuals in the appropriate level of care in the correctional facility?
So based on the screen, what we're really looking at is the people that are dependent, so the ones that score 3 or more, which is the scoring for dependence. All of the programs that we're referring people into from the reception centers are therapeutic community model programs, so they're high intensity. So unfortunately, we don't have different levels of intensity within our Illinois Department of Corrections. And so based on the resources we do have, we focused on that high-intensity population getting high-intensity treatment services and being moved into those programs. And again, not everybody's getting in because we only have, a limited number of beds. There are, just to say one more thing, there are drug education programs in other places, and a lot of the people that score below 3 are able to access those programs, but they're really not geared towards the high-intensity dependent offender.
Right. I think really important point there as well on that. Maybe talk a little bit more, and I don't know if this is a follow-up to sort of the question that you were just answering, but a question came through about the treatment readiness programs you were referencing, and the question was sort of, can others use these treatment readiness programs? I don't know if they're wondering if it's something that's manualized, or there are examples of treatment readiness programs that you would recommend.
Yeah, we use, we're using one of the manuals from TCU called Getting Motivated to Change. There is a number of different manuals that can be used for treatment readiness. There's actually one on anger, and again, these are all available on the TCU website. There's one on anger, one on HIV and AIDS. And so the program that I referenced that we used to have at Robinson, we actually took people through all of the manuals. What we chose to focus on now, just because we sometimes have limited time with people, is really honing in on motivation and using the Getting Motivated to Change manual from the IBR website.
Question, I think, maybe for both of you about whether if you find these strategies work for youth, young adults as well.
Well, we are currently in the process of adapting the instrumentations and some of our motivational enhancement interventions for use with adolescents. These materials have been originally developed for adults, including the instrumentation, and we know there's a need to adapt it for adolescents. There's a NIDA grant that Dr. Flynn and Daphne Knight are heading up that involve a number of different providers across the U.S., and hopefully we'll have some materials ready to distribute as part of that project in the next couple of years.
Okay. Question about whether or not all the TCU assessments have been validated as best practices.
Well, that's a tricky question. In terms of what's listed in NREP, we have the mapping strategy, which is used across all of our interventions, is listed there. The individual interventions, we have a number of those that have been evaluated that we've published on. Our briefer interventions that have been more recently developed will be coming out. The results from those evaluations will be coming out in an upcoming special issue of Journal of Offender Rehabilitation, hopefully in the next few months. Overall, what we see pretty much across the board is that all these interventions are having a positive impact on knowledge and attitude, and to some extent, to a lesser extent, on some behavioral changes. But again, keeping in mind, these are all 4 to 6 sessions where the real intent is around readiness and initial change, not designed to replace, more fully developed curriculum. These are really designed to help augment the types of curriculum that are already in the field. So the changes we would expect are more specific to knowledge and attitudes, and some behavioral changes as specifically addressed by each of the interventions.
Okay. And then a quick point of clarification about the assessment tool and whether that's the one that measures hostility.
Yeah, the SEST includes psychological functioning, social functioning, motivation, and when repeated over treatment, it would also include the engagement scales. The hostility is included in the social functioning section of the SEST, and we have, again, broken that out. If you want to just do the social functioning, there's a one-page form specifically designed around social functioning. The larger form, the SEST, is just the compilation of those forms.
Okay, great, thank you. Where do 12-step programs fit into treatment?
Janelle, you can answer that one.
You want me to take that one? Yeah. We strongly encourage it. We believe it is the thing that will sustain people in the community. One of the things I'll say as well, one of the things we've developed here at TASC through some work that's been done in other places in the country is a model called the Winner Circle, which is specifically geared, they're groups that are specifically geared towards people that have addiction issues, but also the added stigma of a criminal record. And so it's a place, sometimes our clients find that not all of their issues are getting addressed in 12 steps, and so they also join a Winner Circle group, which is a peer-led, peer-run group of former offenders that are, continuing to work on how to be successful in the community. But we strongly encourage 12-step involvement as part of their ongoing recovery process.
Yeah, and as one of the manuals that's available for free download from our website, we have something called Managing Your Steps, 12-step guide maps. And this is essentially a set of mapping templates, similar to what you saw earlier, for helping clients work through their 12-step program. Includes maps to explore the popular AA slogans, the 12 traditions, and the Serenity Prayer. So really tools that can be used along with the 12-step process.
Great. I would also add, a number of communities have recovery organizations that run a number of different programs, services in the community that are peer-based and really extend beyond 12 steps. So create sort of, I think, a menu of options for people in terms of social activities and interacting with peers. And if folks are interested, I think the best place to figure out if your community has a recovery community organization is Faces and Voices of Recovery. And if you just Google their website, I think the website is sort of the name of the organization. They have a portal where you can sort of click on different states and regions and get a listing of different organizations that focus on 12-step and then a range of other sort of peer support mechanisms. A question about whether screening should always be followed by a full-blown clinical assessment to identify substance dependency.
I'll take a first shot at that, and then, Janelle, you can actually answer it in terms of practice. Yeah, from a theoretical perspective, it's always ideal to follow screening with a more full-blown assessment. In correctional settings, we often find that in diagnostic and reception centers, there's just not time to do the full-blown assessment, that you have to do a quick sorting, if you will, and screeners help in that process. Once they get to a treatment facility, for example, that's the opportune time to do a more in-depth clinical assessment that can really be used to guide the treatment plan and what's actually provided in terms of services. Having said that, I know a lot of correctional settings do not have the time and resources available to do the full-blown assessment, and I think oftentimes we inadvertently place individuals in the treatment that don't need it or don't provide treatments to those who do need it because we haven't done the full-blown assessment. But from what I've seen, it's really ultimately a matter of resources and time and financial resources as to whether or not that can be done.
We do a full assessment once the offender arrives at the prison-based treatment program. So the screen is then followed up with a full assessment once they enter treatment. One of the things that we're seeing is less than 5%, and this is, again, almost 6 years worth of data out of Sheridan, less than 5% have been found to actually, been a false positive and not appropriate for treatment.
How do you deal with clients not answering questions honestly because they do not want to add to their programming? For example, they answer honestly that they are hostile and then get anger management recommendation. Is that something that either of you have had to deal with in the scope of your work?
It really comes down to how do you get good self-report. And there's what I call justified paranoia in many cases as to not wanting to provide an answer that you think is going to result in something you don't want. The reality is in most systems that do a good job with self-report assessment, they make it very clear during the instructions as to what's being administered, why it's being administered, but most importantly, why it's important to be honest in the responses. I know in some systems what they'll point out is that the client's responses on a form go into the file that is reviewed, for example, during a parole hearing, and that all that information collectively is considered. And if their responses on an instrument aren't similar to the responses or similar to other pieces of evidence in the file, then oftentimes it doesn't look favorably. It's not a favorable decision based on the inconsistencies. So encouraging clients to be consistent, particularly with what's already in the file, I think helps tremendously in terms of attaining, valid self-report. But again, if they're refusing to answer, that's really more a policy issue. How does any agency deal with clients who refuse to participate, refuse to answer other instruments? That's really not specific to the instrument. It's really more specific to policy, and what practices are in place to deal with that.
So recognizing that there are different degrees of co-occurring addiction and mental health disorders, a question came through about whether or not sort of the tools and programs that we've referenced today, sort of how they can be applied to individuals with co-occurring addiction and mental health disorders.
Janelle, you want to take a shot at that one?
I was going to ask you if you wanted to. Most of the clients that we are seeing, a high percentage of the clients that we're seeing that are coming into the reception centers have co-occurring disorders. Our screening process at the RNCs includes not only a screen for substance abuse, but also a mental status exam and a brief interview with a psychologist. And so I don't think the tools can be used for a co-occurring disorder population. And Kevin, I think the point that I want you to jump in on is there's also a tool that looks at mental health that's been developed by TCU.
Right. We do have one as a screener, and that is based on the K-10 from the World Health Organization. It's not one we developed. It's one that is used worldwide. But, again, it's not designed as a diagnostic, but a quick screener. The tools themselves, whether we're talking about the instruments or the interventions, are applicable for use with co-occurring populations as long as they're not too severe. But I know you're going to have a webinar later on that's going to specifically look at or discuss co-occurring disorders. And I think there are a number of specific tools and interventions that are appropriate for that sample that you'll probably be going over at that time.
Question for Janelle, but then Kevin, if you are familiar with any programs across the country about whether or not you have any reentry halfway back options dealing with treatment after offenders are placed on parole.
Well, we're very fortunate because part of the funding for our Sheridan and Southwestern Correctional Center programs includes funding for community-based treatment. So we're very lucky because we can transfer people immediately from prison-based treatment to community-based treatment, and that includes all levels of treatment. I know that there are some jurisdictions, Kevin, you probably know if Texas is still doing this, that have done transfers from prison-based treatment into a standard step-down halfway house in the community. In Illinois, we kind of use the full range of kind of the full continuum of treatment based on their risks.
Yeah, the best model that's out there right now is probably with the BOP and the Administrative Office of the U.S. Courts Federal Probation, where there is a nicely defined step-down process from their residential drug treatment to a residential correctional center in the community, and then on to probation, outpatient types of services that are offered to these individuals. Texas has had over the years a comprehensive plan similar to that. Unfortunately, like with many states, the financial crisis has really curtailed the services that can be provided to these individuals. And that's why I think now it's more important than ever that we focus what limited resources are available in the community for these individuals, really to be focused on those who pose the highest risk.
Now, I know Pennsylvania, I believe, and a number of states have facilities that they sort of refer to as halfway back options, where they will place people who are on probation in the community and maybe relapse or need a higher level of treatment. Rather than sending them back to prison, revoking them, they'll put them in these sort of halfway back facilities. Does Illinois or Kevin, do you know if there are other places that utilize that approach for people that are already in the community?
Well, there are a number of
go ahead, Kevin.
No, I was going to say there are a number of places that do, but Janelle actually has a great model, particularly for those who relapse and can benefit from the use of medication-assisted treatment.
Yeah, I have two models, I guess, now. Just to answer the halfway back question, we do have a halfway back program that is a community-based program. So for somebody that is on the verge of returning and, potentially in warrant status, they are allowed to go into the halfway back program as kind of the last option before return to prison. The issue that we have is it's, one program in Chicago that houses 40 people. So unfortunately we did have two and funding reduced it to one, but we have used that model to impact recidivism and try and keep someone in the community before they return. The model that Kevin is mentioning is for the opiate-addicted population, we've been doing a medication-assisted treatment pilot for those that relapse to work with the individual to get them on Suboxone and back into treatment as an alternative to returning to prison. And we don't have, It hasn't been in operation for very long. We have a small sample right now, so the results are forthcoming, but just on a case-by-case basis, we're seeing some pretty good success in that model.
Okay. A question about sanctions. During the first part of the webinar, I briefly talked about the effectiveness of sanctions. Can you please explain further? I'm a case manager in, I think, the treatment center, maybe, I'm not sure what the acronym is, and we use a sanctions schedule.
Right. It's not that sanctions in and of themselves aren't part of a larger piece of the puzzle to address addiction. It's just the evidence is pretty clear that if all you do is provide sanctions without any rehabilitative service delivery option, that what you end up with is, number one, increase in technical violations. There's ample evidence now to show that the more intense the supervision, the more likely you're going to get increased technical violations, which is often part of a more intense punishment option. The other is that through years of behavioral research, the evidence is clear that achieving behavioral change is not readily achieved if all you do is punish, that there has to be some reinforcers involved, some positive reinforcers involved to achieve behavioral change. So the slide that was referenced, the meta-analysis that was conducted by Don Andrews, was looking at boot camps, for example, where the old-time boot camps that were strictly about a regimented discipline approach compared to boot camps, for example, that had a therapeutic component added to it, that the ones with therapeutic component added to it, some of those had some positive outcomes, but the boot camp model by itself was associated with very little, if any, improvement. And sometimes there were what would be called iatrogenic effects, that it actually made the return to custody increase as if when compared with not having participated in the boot camp.
Here's an interesting one. My state has a random enumeration recruitment process for treatment behind the walls. How did you overcome this barrier in the prison system?
I'm not sure what that means.
I have that they just randomly get assigned a treatment by number?
Well, I would find it hard to believe that any state randomly assigns to treatment, and maybe of those eligible for treatment.
Yeah.
There's limited slots, limited availability, and there may be more of a randomized process. The reality is I think that's true for almost all states and jurisdictions, and that the number of services available just can't meet the demand that's out there. And again, that's where I think most states now are recognizing being smart about providing treatment means making sure that those with the more severe needs get prioritized for placement into those services. Illinois is a great example of that, where those with greater needs are the ones more likely to be placed into those treatment slots, that it's not simply a first-come, first-serve process.
Okay, if we could get maybe two more questions, then that would be great. There's a ton of them, but we're just not going to be able to get through them all, unfortunately. How does Illinois balance screening and placement of offenders with a judge's sentencing order? For example, a judge orders offender to receive drug treatment, but screening determines the offender's lower risk severity. I know this is a huge issue throughout the country. Janelle, is that anything that you guys have had to deal with, or Kevin, in your experience?
Interesting, because actually that was something that I was dealing with a couple years ago that's kind of not come up recently. The department was looking at putting a administrative directive in place related to judges' orders. I think right now what's happening with that is it's a little tricky. So let me just talk about the administrative directive. What they were looking at is that if somebody came in with a judicial order for treatment in prison and for whatever reason refused treatment services, that they could be sanctioned for that and that it would impact their good time. Unfortunately, that has not been implemented. I'm sure that there are cases that come through where there's a judge's order and their self-report screen is below the, dependence threshold, I think in those cases, what we need to take into consideration is the order and then also the additional information, because clearly there's other information that would then tip the scale to somebody being dependent. Currently, though, if they're dependent and they refuse treatment, there are no sanctions for that right now. So they don't necessarily get into treatment even on a judge's order.
Okay. I will add, I know a number of jurisdictions have it set up where the judge is recommends an assessment and then is sort of bound to sort of order whatever the assessment says. So rather than giving them sort of the ability to directly place people into treatment, that they
just follow the recommendations.
Right, exactly. That you have to get an assessment and do whatever the recommendations say. And I think even within sort of the judicial community, that is sort of a concept that is increasingly being embraced, and a lot of peer sort of conversation from judge to judge about how that may be a recommended way to go.
We're even seeing that with our probation population as well.
That's great.
When people are ordered, Sorry, Alexa, go ahead.
Excuse me. One last question before we need to sign off. And this is back to Kevin and then maybe Janelle as well. In regards to the assessment tools, are they in a system or platform that allows you to share the information across agencies like a shared database?
No, they're not set up in a system like Compass in terms of a large-scale database. The instruments themselves can be downloaded and administered by hand. We have Excel files where those data can be entered into and reports generated and printed and put into files. There are some groups out there that have created centralized platforms for wide-scale administration, but we find that for most facilities, they need something local that they can work with. We also have a Scantron option that the information on that's available on our website, where the forms, if they're being administered in large-scale applications, can be administered as part of an optical scanning process.
Great. And with that, I want to thank, again, both our presenters for taking the time today to participate in this webinar. This is going to conclude our webinar. I want to thank everyone for attending and participating. Thank you to the Bureau of Justice Assistance for sponsoring the event. And again, thank you, Dr. Knight and Ms. Pruder. And then just want to remind everyone that's still hanging on the call that a recording of the presentation and slides will be available online in the next few days on our website at www.nationalreentryresourcecenter.org. Thank you so much.